person, and I offer to you as one of our fun Friday afternoon exercises to pull out your favorite data set where you have a superclad calculated at 3 centimeters depth and just see how much dose is at some place that's 2 centimeters deep rather than 3 centimeters, and you'll realize that there really can be a problem if you specify your supraclavicular fields at 3 centimeters depth rather than looking to see where the actual supraclav nodes are and prescribe it to the depth of those nodes, or at least put the brachial plexus in so you can see what you're doing to it. And so this is what one of the references from the Red Journal gave for what they recommend that your brachial plexus should look like. And again, down in the supraclavicular area, it's real easy to end up with doses that are pretty high unless that's contoured. Let's talk a little bit about brachial plexopathy. This is something we don't really run into a whole lot, but it does happen. It actually happens more commonly in our breast cancer patients who are getting comprehensive breast and lymph node radiation than it does for our head and neck cancer patients. And also, the breast patients also have had the disadvantage in that they've gotten a lot of chemotherapy. And whether you give the chemotherapy before the radiation or you give it at the same time as the radiation, you can increase your risk of brachial plexus injury. And this is what happens if you get a brachial plexopathy. On the right side of the screen, you have your nice normal brachial plexus, and on the left side of the screen, you see somebody who's got brachial plexopathy, and the MRI scan shows the irritation, the inflammation, the edema, and the swelling of the brachial plexus nerves. And what the patient's going to experience is a lot of burning, numbness, a little bit of maybe some pain, and maybe some profound weakness in the brachial plexus. And so that's something that we don't want to do to people, and that's why we contour the brachial plexus. Brachial plexopathy actually comes in two varieties. The one that most people talk about, the classic form, it's a chronic progressive syndrome. It may start 6 months after radiation, or it could even come 10 or 20 years after radiation. And even though you haven't seen much brachial plexopathy in your head and neck patients or in your breast cancer patients, I wouldn't take much solace in that, because a lot of people haven't been treating their patients with IMRT for more than a couple years, and they may not see their brachial plexopathy for a couple more years. And it's better to try to avoid the problem than to wait until you've seen your first 5 or 6 or 10 patients get that. Unfortunately, patients usually develop weakness, numbness, and other sensory problems. Severe pain, there should be another E on that. Severe pain is less common with the radiation-induced brachial plexopathy than it is if tumor goes into the brachial plexus. If a person gets severe pain related to brachial plexus, I'd be more worried as a doctor that their tumors come back than I would be from the radiation. The bad thing about classic brachial plexopathy is it does not go away. It gets worse and worse and worse until the patient can't use their arm at all. And that's not a fun thing. And if you think about how young some of your breast cancer patients are, that's not a good place to go. There's another form of brachial plexopathy that's relatively rare. And this is the one that's more likely to scare the doctor and the healthcare team, because rather than something that came on 2 or 3 years after radiation treatment, this is something that can start 3 to 6 months after a person finishes the treatment. All of a sudden, they've got numbness, they've got some pain, they've got weakness in their hands and their arms. But fortunately, the atypical form, if you just sit tight and don't do anything, it usually will go away in another 3 to 6 months. But it's probably going to scare your doctor if he runs into a patient that has it. And again, if you can contour your brachial plexus and keep your hot spots out of there, you can keep your doctor out of trouble. So just kind of reviewing a few things, whenever patients get chemotherapy, either before radiation or during radiation, the chemotherapy itself, especially the kind of neurotoxic chemotherapies, will increase the patient's risk of brachial plexopathy. We've also run in literature to some patients with brachial plexopathy who've had stereotactic body radiation therapy. There are a lot of places now, like us, where we're given 3 fractions of 20 gray. Some people given 5 fractions of 12 or 14 gray. If you have a tumor in the upper lobe of the lung, anywhere near that lung apex, you really, really need to contour the brachial plexus. Remember, all you have to do is follow that subclavian artery and put a little margin around it, and then you'll miss the brachial plexus and hopefully avoid a long-lasting problem. So just to sum up, the brachial plexus is important. The main thing to do is to look for that anterior scalene muscle. It's usually the easiest of all the structures to see, and know that a little bit below that has to be the middle scalene muscle. And I would just go ahead and contour both the upper and lower parts of that and use the subclavian artery as a landmark when I get to the lower portion. So help your doctor out and contour that. And let me show you some examples of how I would contour the brachial plexus, because I think it's simpler than the other methods that you're going to find published. So all that I suggest that you do is you can easily figure out where C5 and T1